This is Charles Clinton speaking about the summary on Chapter 92, Neurological Disorders and Cardiovascular Disease. Last video we couldn't wrap it up since YouTube just lets us upload 15 minutes. So we'll wrap up with the second part. If you want to see the first part, look it up under this same name. Just change part 2 for part 1. Now we're going to talk about the mitochondrial disorders. They're a heterogeneous group. Remember that the mitochondria is inherited maternally. Mom passes mitochondria to all her siblings. So all of mom's offspring will be affected. Penetrance may be diverse since you may have some patients with more or less healthy mitochondria and affected mitochondria. So penetration may vary. We have the Kearns-Sayre syndrome, which is the most frequent of these mitochondrial disorders is MELAS. I'll tell you what each one stands for. Then MELAS stands for mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. Then we have the MRF. MRF means myoclonus epilepsy with red ragged fibers. Then we have the Kearns-Sayre syndrome and the Leber hereditary optic neuropathy. What are the clinical manifestations? We can see that the Kearns-Sayre produces a progressive external ophthalmoplegia. There's pigmentary retinopathy and AV block. You may also have associated diabetes, deafness, and ataxia. How do I remember Kearns-Sayre? Well, I associated Kearns with the juice brand. If you've ever had a Kearns, you know it has an exquisite, strange, and toxic taste with pretty colorful fruits surrounded by a white background. So these colorful fruits remind me of the pigmentary retinopathy. And when you're drinking a Kearns, it's hard to look at your sides. You're mainly locked into that juice. Then you have external ophthalmoplegia and AV block. Okay, that's a form of remembering it, not that complex and somewhat strange, but if it helps out, great. What about MELAS? MELAS is mitochondrial myopathy, encephalopathy, lactic acidosis, and stroke-like episodes. Remember that all these mitochondrial disorders have to do with the generation of ATP or energy. The mitochondria is mainly associated with the respiratory, the electron transport chain, which is in charge of making all those ATP, and you need oxygen too for this to happen. So those tissues that need a lot of ATP may be affected mainly. That's why we can see fast twitch muscles and also the heart being affected by this. Cardiovascular manifestations in Kearns-Sayre, you can see conduction abnormalities and permanent pacing, usually in patients by age 20. There is increased pre-excitation in these mitochondrial disorders, mainly in the Leber. Pre-excitation, which is synonymous with a short PR interval. And MRF and MELAS, both of them starting with an M, are a little different. If you fill in the upper portion of the M, it looks like a triangle, and this might represent a V, ventricle. How is the ventricle in MELAS and MRF? It's hypertrophic, or it might be dilated. So it affects the structure of the ventricle. What's the treatment? Kearns-Sayre. If these patients have also the conduction disease manifested, think about a pacemaker, and obviously follow these patients with uh, echoes. What about the spinal muscular atrophies? So these are lower motor neuron disorders. The most common one, there's type 1 through 4. The most common one is Wernicke-Hoffmann. And here, in general, there's a progressive symmetrical proximal muscular disease. It is the leading cause of death in infants, infant death. So type 1 is Wernicke-Hoffmann, and there's also 2, 3, 4. Chromosome affected is chromosome 5, and in general all of these have a gene which is affected named survival motor neuron. So if the survival motor neuron doesn't survive, motor neurons will die, and if motor neurons will die, you'll see these manifestations. In 98% of these patients, you have this alteration on the SMN gene. Cardiovascular manifestations are coexistent complex congenital heart disease, mainly associated is atrial septal defect. You can see some arrhythmias, mainly supraventricular arrhythmias, and that's the most common cardiac manifestation. What's the treatment? For type 1 or Wernicke-Hoffmann, it's a devastating disease which the lifespan is so limited that there's not much to do for now. Now let's talk about the desmin-related myopathy. Let's get this going and make this more colorful. So you can pause the video if you want to read this, but I think my drawings are more interesting. Not nicer, I might say, but they're more interesting. So desmin has a capital D, it's autosomal dominant inheritance. There's a decrease in the production of desmin, which is an intermediate filament which gives structural support to cytoskeletons of what? Of skeletal muscle and cardiac muscle on the right. So, back to the left. It explains 1 to 2% of familial dilated cardiomyopathy. It is pretty rare, but patients with the diagnosis, around 50%, have dilated or restrictive cardiomyopathy. Its onset is late 20s. As you can see in the black figure, there's distal weakness that goes proximally. The diagnosis is mainly muscle biopsy showing deposition of desmin immunostaining. Treatment or prognosis. You have to monitor for conduction or structural disease and prophylactic ICD. Now let's go on to Guillain-Barré. Again, pause if necessary. We're going to the juicy, nice drawings. Then up left, you have virus or bacteria affecting gut or lungs. This in 6 weeks or less will produce the most common cause of acquired acute inflammatory demyelination, which is called Guillain-Barré, in 1 to 2 persons per every 100,000. This produces the symptoms seen on the right in the black figure, which shows distal to proximal weakness, symmetrical, and it may end up affecting cranial nerves and the autonomous nervous system. This autonomous nervous system affection, or not affection, this alteration in the autonomic nervous system is the main reason you'll see cardiac alterations, which may manifest as changes in blood pressure, hypertension, hypotension, and also brady or tachycardia. 25% of Guillain-Barré patients need mechanical ventilation. Sorry. Around 15% of hospitalized patients for Guillain-Barré will die, 15% mortality. Some risks associated to it are DVT and thromboembolism, arrhythmia, and mechanical ventilation. Treatment is mainly supportive. You could help these patients out in severe cases with plasmapheresis or IV immunoglobulin. This might help some in the recovery of the patient. If the patient is doing tracheal suction, it's risk for asystole. So these patients may benefit from atropine or isoproterenol. And the prognosis is pretty good when there's recovery. If there's recovery, you almost get complete recovery. Myasthenia gravis. Here's the drawing once again. Up left, acetylcholine nicotinic receptor. So there's antibodies directed to these receptors. This affects mainly the eyes and the face and may go on to larger muscles like the limbs. With fluctuating weaknesses, there you can see the patient with ptosis. He's already tired of the repetitive use of his eyelids. Fluctuating weakness. Presentation is earlier on in females. The prevalence is 50 to 125 per every 1 million. It is associated with benign tumors and malignant tumors, mainly with thymomas. And one part of the treatment is to take the thymoma out and anticholinesterase. Okay, so anticholinesterase. Yeah, you want more acetylcholine in the synaptic space. How does this affect the heart? It has shown to make a pattern similar to myocarditis in the biopsies or the autopsies of these patients. 16% have associated cardiac disease. One of the first manifestations in the cardiac system is the heart is arrhythmias. SUDEPs means sudden unexpected death in epilepsy. Around 2 to 17% of these patients die due to SUDEP. Cause is not that clear. It may be apnea, respiratory secretions, acute pulmonary edema, or arrhythmias. Risk factors are increased number of meds used to control this, non-compliance of the patient for using medications, prolonged episodes or increased frequency of episodes. Treatment and prognosis, watch out at nighttime, they may do this SUDEP and have in your differential primary arrhythmias before thinking about these other causes. First, you have to rule out primary arrhythmias. If the patient does bradycardia and ictal symptoms, well, you're well off placing a permanent pacemaker in these patients. Acute cerebrovascular disease. Look at the drawing. It may be ischemic or hemorrhagic. Usually hemorrhagic affects more the cardiovascular system. So mainly in the subarachnoid hemorrhage, you'll see 70% of EKGs with changes, which are mainly ST and T segment changes or pathologic Q waves. This subarachnoid hemorrhage produces hypokalemia, and this may lead to prolonged QT. All this may produce a substrate for ventricular arrhythmias. Also, there's neurogenic stunned myocardium, which means that it is reversible if you treat the cause. And it is associated with apical type Takotsubo. Females have higher risk of necrosis, and in general, patients may also produce pulmonary edema, which is multifactorial, cardiogenic, also associated to hypertension, and neurogenic. We gotta wrap this up. And Q waves that are inverted.